Good morning, everyone. Thanks for joining us today. I'm Ophira Ginsberg, Senior Advisor for Clinical Research with the NCI Center for Global Health. In 2021, in commemoration of the CGH's 10th anniversary, we launched the new NCI Global Cancer Research and Control Seminar Series. In this series, we feature talks by researchers and cancer control experts working in global oncology and provide opportunities for discussion and collaboration around impactful and innovative work that addresses cancer morbidity and mortality worldwide. In today's session, I'm very happy to welcome Dr. Carlos Rodriguez-Galindo, who serves as the Director of St. Jude Global, Chair of the Department of Global Pediatric Medicine, Executive Vice President, and holds the 4 Stars of Chicago Endowed Chair in International Pediatrics Research at St. Jude's Children's Research Hospital. Dr. Rodriguez-Galindo is leading an effort by St. Jude to ensure childhood cancer patients have access to quality care no matter where they live. As a native of Barcelona, Spain, Dr. Rodriguez-Galindo first came to St. Jude in 1994 as a postdoctoral fellow, went to serve as clinical researcher and faculty member for more than a decade before accepting a position in Boston. At the Dana-Farber Cancer Institute in Boston's Children's Hospital, he was director of the Pediatric Solid Tumor Program, medical director of the Clinical and Translational Investigations Program, and director of the Global Health Initiative in Pediatric Cancer and Blood Disorders. He also served as professor of pediatrics at Harvard. He has a very long, amazing career and bio, but I just want to say a few words about what led us to this talk today. In 2015, around the time you and I met, Carlos, at WHO, Dr. Rodriguez-Galindo returned to Memphis to lead a new department of global pediatric medicine and a new initiative, St. Jude Global. Now, at that time, St. Jude had 24 partner sites already in 17 countries and addressed 2.4% of the global childhood cancer burden. Under his leadership, the program aims to expand St. Jude's reach to 30% in the next decade and to develop intervention models to ensure access to quality care for all children with cancer in the world. Finally, at present, St. Jude's Global Alliance includes more than 170 institutions from more than 60 countries. And Dr. Rodriguez-Galindo led an institutional effort to become the first World Health Organization collaborating center for childhood cancer. I'm sure we're going to hear a lot about that now and about all his great work. I'm going to give the floor to you in just one moment, Dr. Rodriguez-Galindo. A few logistics before we begin. As a note, today's presentation is being recorded and will be available on our website at cancer.gov/global health. And you can find information about future presentations on our site and by following us on Twitter at NCI Global Health. Questions this time, for those of you who've been part of the seminar series, this time we're going to do our Q&A immediately following, but by asking people to raise their hand using the feature found in the reactions under Zoom and wait to be called upon, or you can type your question in the box. If called upon, it would be great if you can unmute yourself and ask your question. And now we'll begin the presentation. Welcome, Dr. Rodriguez-Galindo.
Well, thank you so much, Ophira. It's a pleasure to be here. Thank you so much for your kind invitation and for your kind words as well. So I'm going to try to share my screen, and please confirm that you see the right screen since I have 2 monitors here. Hopefully it's okay.
Yes,
if I don't hear otherwise. Okay, perfect. So thank you so much again, Ophira. So over the next few minutes, maybe most of the next 45 minutes to an hour, we'll try to go over some of the initiatives that are happening, not just at St. Jude, but as Ophira said as well, through the WHO and other United Nations agencies to try to address the childhood cancer burden in a way that we all think that should be done so that every child everywhere should have access to quality care in the next decade. And so this is the challenge that we are facing as today. So the cure rates for childhood cancer are now above 80% with modern therapies and supportive care in Washington, D.C. or in Memphis, Tennessee. However, we know that each year close to 400,000 children develop cancer worldwide, and more than 80% of these children live in countries with limited resources. As we will share in the next few slides, we realized that the global cure rates for childhood cancer are way lower than that 80% that we see here in our own country. And in fact, most of the children with cancer in the world die. So we haven't made that much progress over the last 6 decades. So the challenge of our generation will be to decrease these global disparities and share the progress that we have made in advancing cures for children with cancer all over the world. So for that, I would like to walk with you through what has happened over the last 2 decades. What is this roadmap towards where we are today, this global response? And so I will start with the United Nations Millennium Development Goals, when there was a call to reduce the under 5 mortality rates by 2/3 by 2015. And we have made major progress on that. And I will not dwell on that. What I want to share is the figure on the right side of the slide that we developed with Paola, one of our junior faculty here a number of years ago. And this is basically an estimation of what is happening in this epidemiological transition. So from left to right, you see the poorest countries in the world to the richest countries in the world, West Africa and North America. In blue, you see the reported incidence of childhood cancer, which we know that is reported to be twice as high in rich countries versus low income countries. In red, you see the under 5 mortality rates, which are obviously very high on the left, very low on the right. And to me, what happens is this magic point or virtual point where these two lines cross. As countries move from left to right, healthcare systems improve, maternal and child health systems get stronger, the under 5 mortality rates drop, the kids survive longer, there are less competing risks for death, and the reported incidence or the burden of childhood cancer increases. And this is basically this epidemiological transition. So the cancer in children will become a more and more important problem as countries evolve. But the other point that I would like to make is what you see in green, which is the cancer-related deaths. So the cancer-related deaths are low in Western Africa just because children die of other causes. They are low in North America because we cure children with cancer. But this is not a linear curve, it's a polynomial curve. So as countries move from left to right, the incidence or the burden of childhood cancer increases. And what you see is that countries are completely unprepared to address it. And so the childhood cancer related deaths increase as countries move from left to right. So this is the epidemiological transition that we are seeing these days. And so over the last 2 decades, this concept about addressing non-communicable diseases, including cancer, has continued to evolve. I'm not going to get into much details about that, but you know that through the United Nations and then the World Health Assembly, there was that resolution to really address NCDs with a target of 25% reduction in NCD mortality by 2025. And that eventually led to incorporating a lot of these concepts about addressing NCDs in the United Nations as sustainable goals. So SDG 3 is to ensure healthy lives and promote well-being for all ages, including children. So continue to reduce the deaths in newborns and under 5, to reduce the premature mortality from NCDs. And then most importantly is also to achieve universal health coverage. And that should include access to essential diagnostics and medicines. So this has been quite remarkable progress over the last 2 decades in mobilizing the international global stakeholders. So eventually this led to the World Health Assembly Resolution 7012 in May 2017, just less than 2 decades after studying this talk about NCDs on cancer prevention and control in the context of an integrated approach. And that is calling for governments to address childhood cancer care as well as part of the cancer burden in general, and also to address that using innovative financial approaches to promote equitable and affordable care. So this is where we are. This is where we are. In 2017, there was a call for action, but the question is, what do we need to address? What is the global burden of childhood cancer? So this is part of a work that we did through a Lancet Oncology Commission, and is a modeling of the estimates of the real burden of childhood cancer. To the left, you see the reality that about 400,000 children, a little bit more than that, are currently developing cancer every year, and yet only half of them are diagnosed. So this is the reality, that half of the children that develop cancer today in the world die before even being diagnosed. What you see in the right is the cost of inaction. We don't do anything. Over the last 3 decades, you will see more than 13 million cases diagnosed, and half of them will die undiagnosed. And in the future, you just see what will happen in the next decade, how much this disparity will continue to widen to 7 million versus about 3.5 million. And so this is the reality today. And so about 50% of children with cancer are not even diagnosed. Where are these children? So the majority of these children, as you will, accurately guess, are in low and lower middle income countries. But even in upper middle income countries, close to 30% of children don't even get diagnosed. Even in high income countries, about 5 to 6% of children don't even get diagnosed with cancer. So this is a major challenge, addressing the burden and bringing patients to a diagnostic path. But then what is the overall outcome? And so considering children that are already being diagnosed, the outcomes are very poor. So you can have already mentioned the late presentation, underdiagnosis, but then even for those that get diagnosed, the toxicity of treatment, malnutrition, abandonment of therapy, deficient nursing, deficient supportive care, access to drugs. Bottom line is this part of another Lancet Oncology Commission work. Less than 30% of children with cancer survive. Less than 30% of children with cancer today actually are cured. So why is that? So I think this is a multifactorial issue, but when we try to think about addressing priorities at a country level, in countries with limited resources, addressing childhood cancer never bumps up to the top of the priority list. Obviously, as it should be, we need to address communicable diseases, invest resources in what we can prevent. Then, as we have seen over the last 2 decades, there has been a change in dialogue so that we can start addressing non-communicable diseases, but we start with the most prevalent diseases, cardiovascular disorders, diabetes, obesity, etc., and then cancer, and then childhood cancer. And in general, childhood cancer tends to be included in the big concept of cancer when should be addressed independently. But there are different ways of addressing this burden. We tend to assume that childhood cancer's burden is very low and that therefore should not be a priority. But this is a work that we did with IHME, with Lisa Force and Nikhil Bhakta, and that's trying to take a look at the burden of childhood cancer in a different perspective, that is using disability adjusted life years, so the DALYs. So because what is it that we are losing by not addressing childhood cancer, the lives of the years of life lost. And so what Nikhil and Lisa did was put together the most common cancers of adulthood, and we bring childhood cancer one single category. So when we put childhood cancer as a single category and we compare it with all the other cancers, at the global level, in terms of DALYs, childhood cancer ranks number 6, above cervical cancer, prostate cancer, and brain tumors, for example. But when you look at the right, in low and lower middle income countries, childhood cancer ranks number 1 when we look at DALYs. And that's a different way to bring this topic for discussion, say, with the government, for example. Another way of looking at that is also how much does it cost? Is it cost effective to take care of children with cancer? Also work that we did as part of the Lancet Oncology Commission help us understand how we can itemize the costing and how we can address the cost effectiveness of childhood cancer, also as we try to bring this topic for discussion with governments. So through work with microcosting that we did in Ghana, in El Salvador, and in Mexico, you can tell that more or less we see a correlation that basically taking care of a child with cancer is about between 6 and 7 times the GDP per capita. And when you run that through a cost-effective model, in each one of those countries, the cost per DALY averted was cost-effective, even to very cost-effective. So this is another way of bringing the topic for prioritization to the governments. And also that led to additional studies that we did with through the Lancet Oncology Commission on projecting those costs and the productivity gains of the survivors by investing in childhood cancer. And so in red, you see the treatment costs, the cumulative treatment costs in low income countries, lower middle, upper middle, and high income countries. Then depending on how we calculate productivity using a human capital, full income, or upper limit approach, that is 1 times GDP, 2 or 3, we see that eventually within 2 to 3 decades, there is a complete productivity gain that compensates for the expenses that we have incurred by investing in childhood cancer. So there is a complete recovery of the costs within 2 or 3 decades at all income levels. So when you put it all together, on these costs, at a global level, the projected cumulative treatment costs for a comprehensive scale up would be about $17.3 billion when this analysis was done 2 years ago, and would rise all the way to $594 billion by 2050. But the estimated global lifetime productivity gains would be about $2600 billion, with a net benefit of about a return of $3 for every dollar invested in scale up. So I think that has helped us put childhood cancer in a different concept, in a way that actually can be understood by the stakeholders that have to address and make the decisions to prioritize childhood cancer. So we started with the challenge, so that's the problem, but then yet there are sustainable and cost-effective models that actually we could put together to address the burden of childhood cancer. And so I don't want to forget, we in pediatric oncology, most of us are hematologists and oncologists, and so similar disparities occur for catastrophic blood diseases that we will not be addressing today, like sickle cell disease, thalassemia, or hemophilia, for example. And so this is basically that roadmap that has taken us to understanding the problem and trying to develop these strategies for prioritization. And so in September of 2018, and Ophira was addressing that, so together with WHO and many other stakeholders, we launched the Global Initiative for Childhood Cancer that has taken us to creating this global movement that does not depend on one institution or one particular government, but just brings everyone together. And so we started with May 2017 cancer kind of resolution by the WHO. And so around that same time, we had become the first WHO collaboration center for childhood cancer. And as we started addressing how we can help WHO from a technical point of view in addressing childhood cancer, we also realized that there was a need for a major prioritization in investment as well. And so we made a commitment in July of 2018 with an agreement with WHO to financially support a major initiative for 5 years that actually led then to the launch of the Global Initiative for Childhood Cancer with stakeholders around the world. And that was presented in September of 2018 at the United Nations high-level meeting of non-communicable diseases, being the first time that childhood cancer made it to that stage with that call that we needed to ensure a right to cure, that childhood cancer care had to be addressed and had to be done in a way that would address the global disparities, with a lofty goal that by 2030, that it's 8 years from now by then, so we will be able to double the cure rate, ensuring at least a 60% survival for children with cancer globally, and reducing suffering for all, with the idea that through these efforts, we could save at least 1 million more children. And that has led over the last 2 years with many stakeholders around the world, organizations, governments, academic institutions, to launch these initiatives that has this technical package that we call Cure All, that was released actually about a year ago on International Childhood Cancer Day on February 2021. So the Cure All is the technical package for that, that has 4 pillars of action and 3 enablers. The Cure stands for Centers of Excellence, the U, Universal Health Coverage, the R, Regimens for Management, E for Evaluation and Monitoring, so that there is proper quality assurance and information systems, and the 3 enablers, the all, advocacy, financing, and link policies and governance. And so the cure-all package works around that. Here I want to give credit to the team at WHO, together with the team at St. Jude, led by Dr. Catherine Lam, who for many months and years worked with WHO to develop this cure-all package. And so this is a technical package that is a suite of tools and products to support governments to implement this package in a coordinated approach, aiming to increase the country's capacity to improve quality of services, and is addressed to the policymakers, to the cancer control program managers, hospital administrators, and many other stakeholders. And so this has been working through a model of focusing on specific countries for each region as a way to optimize the model and then expand at a regional level. And here in this map, you see the focus countries that have been set up. And so with a team at the WHO led by Andre Ilbawi, who you probably know, and Roberta Ortiz, with Bente Nicholson as the head of the program, and here at St. Jude, led by Catherine Lam and her team, and many other stakeholders around the world. So a couple of quick examples of how engaging in these type of conversations, where we also bring the cost effectiveness that we had discussed earlier and how to prioritize childhood cancer, engaging in this dialogue. Two quick examples of two of those focus countries, one in the Philippines, one in Peru. These were focus countries that were launched in the first 18 months of the initiative, and both countries enacted laws that facilitated access and financing for children with cancer across the country. In Peru, even supporting families that had to take off work to support their children, providing salary support. So the idea is that through these efforts, you enable governments, you facilitate this process and create this movement within the country that then trickles down to all the providers. And so these are a couple of examples of how this can work. And so we have seen through this roadmap over the last 2 decades on how the world has mobilized, trying to understand the burden and the concept of childhood cancer in a different manner, and then creating the strategies and the packages that provide the assurance that this can happen. But then we have us, hospitals that provide that implementation process. How might we then enable these processes and actually reach the patients? And so I start here with the dream of Danny Thomas, the founder of St. Jude, that no child should die in the dawn of life. And for us, no child should die in the dawn of life has grown to become, our mission or the call for action. And that means no child anywhere. And so in 1962, St. Jude opened its doors. In the 1990s, St. Jude was already working on a lot of international efforts led by Raul Ribeiro, trying to create at least a humanitarian focus on childhood cancer. In the 1990s, the global health agenda was communicable diseases, infectious diseases, preventable diseases, etc. So a global initiative in cancer, particularly in children, was not really well structured at a global level. But then by 2016, St. Jude made the decision of bringing this from a humanitarian effort to an academic effort, with establishment of the Department of Global Pediatric Medicine to improve our knowledge on pediatric oncology and blood disorders. That led through a 2-year strategic plan process to the St. Jude Global Initiative, which a commitment by the institution to address global disparities. And that led to them bringing partners together that I will share. That is what we call the St. Jude Global Alliance. And as I shared earlier in this process, we started working with the WHO. We became a collaborating center for the WHO in parallel, and that led us to work in partnership with other organizations like IAEA or IARC, and then to the development of the package. And so that is basically how St. Jude has tried to address that. But I want to focus on the first part, on the top part, how we, St. Jude, as a hospital, as practitioners, try to influence care. And so we do that with that mission, that we would like to improve the survival rates for children with cancer and catastrophic blood diseases through the sharing of knowledge, technology, and organizational skills, with that vision that every child diagnosed with cancer or a blood disorder has access to quality care. And we work through 4 pillars. 1, build capacity. 1, educate the workforce. The third one, advancing research, and then mobilize resources and advocacy initiatives. And so this is how we work. So at the center of our initiative is the patient. But to influence the care of a child, we need to influence how hospital addresses the care of children with cancer. But to address or to change, to influence a hospital, we need to think about how we can influence the country, the region, and the world. We have mentioned already what we do at the global level through the WHO. And so at each one of those 4 levels, we try to develop an implementation methodology that is focused very much on partner empowerment. We do a lot of strategic planning, collaborative workshops, a lot of design thinking, and then we develop structured working groups at each one of those levels, addressing health systems, patient care, education, research, and advocacy and resource mobilization, and working with the key stakeholders, local leaders, governments, and obviously with WHO or PAHO in the Americas. And so that has led us to bring our partners together, and particularly creating regional networks that has been a very important piece of our operational model. And so we have created different regional networks where countries come together, governments come together, programs come together. One is in Mexico, that is called MAS, Mexican Alliance and Jude, HOPCA, that we have been supporting for years in Central and South America, POEM in the Eastern Mediterranean region, CLEHOP in South America, EURADO in Eurasia, ACA in Asia Pacific, and then China as well. But then we have the transversal programs, which are transversal programs, so initiatives that are not region specific, that try to provide a homogeneous implementation across countries and across regions. And I cite here several of the transversal programs that go from critical care to infectious diseases with additional networks that we have created. But you can picture that nursing, palliative care, neuro-oncology, pathology, etc., etc. So that's disciplines that need to be implemented across the regions. And so the regional model provides an efficient and effective organizational structure, and the transversal programs facilitate this homogeneous implementation with the right methodology. And so when we started creating these regional networks, the next thought was, how can we build a global alliance that brings everyone together towards this shared vision that all children with cancer and catastrophic diseases should have access to quality care. And that's how the Jude Global Alliance was born. So we engage in a co-design process, try to be as creative as possible and as participatory as possible with partners around the world to contribute, to drive change, to share challenges and opportunities. And that's how we call ourselves as Jude Global Alliance. We are complete when we are together and we help each other. But this is not about St. Jude driving, it's that St. Jude being a member of an alliance, providing the resources, the empowerment to drive this change. And this is the St. Jude Global Alliance today, with up to 190 institutions in 64 countries, because there is a master agreement. So 141 institutions have completed this agreement, the other 50 are in different process. But this is the idea, to come together with this shared vision. And so what do we do through this alliance? And so we'll highlight a few of these pillars, and hopefully over the next 15 minutes, I can go over that. One is the academy. So the academy is key to us because it's about addressing the global gaps in the workforce. As the WHO says, there is one universal truth, that there is no health without a workforce. We have 2 programs. One is what we call the Jude Global Professional Education Program, led by Daniel Moreira. The other is the Jude Global Scholars Program, led by Dr. Shalvi Puri. And so the professional educational program is addressed to the practitioners with 3 main pillars. One, distance learning. We have a website that we're constantly improving, and we're going to transform quite significantly in the next few years, which is called Cure for Kids, with seminars, e-learning, classrooms, group communications, online meetings, etc., with more than 10,000 active users. Then we have what we call the training seminars, which are competency-based, skill-setting educational programs with a hybrid structure, with distance learning for 3-4 months, depending on the topic, multiple modules that need to the trainees or the students or the practitioners need to go through. Then an experiential affair that usually happens at St. Jude when they come for behavioral change, not classroom teaching, is this is what we have learned. How are we going to change our settings when we go back? Usually about 3 to 6 months. We have had them on critical care, on infectious diseases, on leadership and management, on brain tumors, on palliative care and others, and nursing as well. And so obviously we had to interrupt that during COVID, but we have continued to do many of those just with a remote component of it. And then we have the clinical training programs. I would like to spend a couple of minutes, since many of you attending this seminar are trainees, you are very sensitive about that as well. So these are proper fellowship training programs, if you wish, 2 to 3 year clinical training that are based at partner hospitals and that tend to address regional needs. And so we fund approximately 20 new trainees per year in different parts of the world. And we have an agreement with ACGME to accredit the program. So recently we had the first center in Guatemala that is now an ACGME international accredited fellowship training program. And so, but I will show you how we are doing it in the Americas. And this is led by Daniel. And so we created for the Latin American community a match system similar to what we do here in the US. So 4 partnered pediatric oncology fellowship programs in Guadalajara, Guatemala, Barretos in Brazil, and Uruguay that came together. So there is a joint application, there is a submission, the pediatric knowledge test that is done online, virtual interviews by the selection committee, and then a match system, an applicant ranking that the directors select their students or the trainees select the program. So this way we can create a cross-training and a cross-pollination process across the region. And so here you have the training program and the selected candidates for this year. The trainees in Guatemala will come from Guatemala, Honduras, Nicaragua, and Ecuador. From Mexico will come from Nicaragua, Honduras, Ecuador, and Bolivia. From Uruguay, Bolivia, Brazil, Costa Rica, and Bolivia. The idea is to start creating a Latin American system where there is common language, common training, there is cross collaboration, and that there is system to then follow up. And so this is the first experiment that we did, and hopefully we can continue to work through this model in other parts of the world. The second is the Global Scholars Program. So we started with a Master's in Global Child Health, which is a 2-year competency-based degree program in Global Child Health in coordination with our graduate school. And this is based mostly on health systems innovation and global health. And so, but then we led it to other components. So as the students graduate, they become global scholars. And so they have 2-year funding for projects that are supposed to transform their systems. And then as they complete, they become part of this alumni community. And so that, say, we do 10 per year. So say in 10 years, we'll have 100 global scholars trained in health systems, in transformation, in leadership. And these are the 40 global scholars that we have right now. And you can see that it's very spread across the world. I'm trying to identify these potential leaders that actually can change. And hopefully this will be a good model for others as well to follow. But you combine then the fellowship training programs with about 20 to 25 trainees per year, the Global Scholars Program with about 10 new global scholars per year. That's the idea of start trying to address these global disparities year after year. And the second component, which is as important as the education component, is how to build capacity. And so build capacity is a very broad concept. And so for us, capacity building goes all the way from trying to strengthen the health systems down to quality improvement and everything in between. So how might we address global capacity building in a coordinated manner? And so for that, we started creating what we call the St. Jude Global Adaptation Framework. So thinking about an active cyclical adaptation. We say adapt treatments, adapt interventions, if you wish. We monitor the outcomes, we assess the quality, we intervene and we improve. And that across the world. So the idea is how might we contextualize the childhood cancer treatment? How might we systematically and efficiently monitor burden and outcomes? How might we create a roadmap for improvement and design and scale up interventions. How might we strengthen the health systems? How might we influence policies to make it all happen? And that's basically how we then created the SJ Cares platform. SJ Cares stands for St. Jude Global Childhood Cancer Analytics Resource and Epidemiological Surveillance System. But with the idea of trying to address these how might we questions. And for that, we created 3 units: the St. Jude Global Disease Burden and Simulation Unit, our EPI unit, if you wish, it's led by Nikhil, the Metrics and Performance, led by Paola, and the Health Systems, led by Kat Lam. And each one of those units created the tools that are supposed to address these questions: the registry, the area guide, profile, packages, systems, and policies that I will review very briefly over the next 5 minutes. So the area guide is basically a platform to guide clinicians and practitioners around the world to a treatment that is adapted, that is modifiable, that can be tracked as well. And it's aimed at all practitioners and trainees, at all the multidisciplinary team members. There is no protected health information, and then we can track the user metadata with the idea of improving the system. We have done that as part of a leading from together with SIOP and other organizations like PROS and IPSO, and hopefully will be launched in the next few months with the idea of creating a platform that can be accessible through a computer, through a smartphone, as an adapted guideline to help practitioners around the world provide the best treatment possible for their patients. Then the other tool is the registry that is built on a clinical trial platform with standardized variables, core variables optimized for pediatrics that aligns as well with population-based registries, and with many toolkits online to help the institutions to implement a registry. It's basically an institution, a hospital-based registry based in the cloud that provides as well the opportunity for a global registry to monitor outcomes. Then we have profiles, the Jude Pediatric Oncology Facility Integrated Local Evaluation Tool, which is a 360 degree evaluation of the health service delivery to help the care teams and the institutions to define an improvement strategy. It's not a joint commission coming and telling you what you do right and what you do wrong. It's just to create an opportunity to create a roadmap so that everyone can improve. And so that's an oversimplification of how Profile works, but it's basically based on 12 different modules that address the national context, personnel or patient outcomes or different services, and then provides a very in-depth reporting of those findings in a very interactive manner with score-based results, descriptive results, then an interactive process with the teams that leads to creating a roadmap that then leads to what we call the workshops, that the profile workshops that I will show you in the next slide, with the idea of identifying gaps, identifying opportunities, identifying strengths, and helping the teams prioritize. And so, as we create St. Jude Profile, we develop some participatory, workshops where the teams come together to, analyze those results, and that leads to what then we call the St. Jude Global packages, which is basically usually quality improvement based solutions, but some of them could be educational, some of them could be policy making. So but basically the packages that need to be put in place to address the gaps. And then with the teams, we develop these workshops that try to look at effort versus impact, trying to help prioritize what needs to happen at what time. So these are some of the workshops. We have that's the team in Pakistan to the left, a team in Chattanooga, Tennessee on the right that participated as part of the beta testing. So it's a many-month exercise that the teams do on their own with our own coaching and our own participation to help them advance through that. And so a couple of examples of some of these packages. That is one package that probably has taken the lead in this development. I will not go through the slide because you can identify is a PDSA kind of cycle, which is about administration of antibiotics in the first hour after fever in hospitals in Mexico. And so bringing all these teams together, we'll go to the next slide, bringing all these teams together in Mexico led to creating a national initiative on the golden hour. And so you will see within 2 or 3 weeks almost, or months, since the initiative started, how the percentage of something as simple but as life-saving as administration of antibiotics at the right time increased from less than 40% to close to 80%, and then eventually close to 90%. And so this is part of this exercise that we do with teams at a country level, very specific interventions. And now the golden hour, the Hora Dorada in Mexico, has had a second wave that has more than 80 centers working together on this single initiative to address childhood cancer supportive care with fever and neutropenia management. And that is basically something we do using quality improvement methodology and using improvement science, this approach in collaboration with IHI, Institute for Healthcare Improvement. Another initiative that I want to share is the pediatric early warning system. So we, in all our systems, our hospitals use this the Pew's algorithm. And so if we know that that works for us, why shouldn't it work across the globe? But this will need to be adapted. And so that's an example of approaches using implementation science methodology, and that's led by Asia Gulnik. If you go through many of the centers in Latin America, you will see this color coding, so the yellow, green, and red, because the countries now have engaged in many of these programs in these processes. And so this went through a process of an implementation science framework. So developing first in Spanish in Latin America, what we call EVAD, Escala de Evaluación de Alerta Temprana. And so it was translated into Spanish, it was validated into Spanish, and it showed that we could decrease the clinical deterioration events, reduce PQ utilization, improve communication with cost savings that could then be reinvested to the programs. And so this is the Proyecto EVAD right now in Latin America, with 73 centers in 19 countries working together to implement early warning scores through an implementation science approach. And the last one I want to mention is the policies and systems. All this needs to happen within a context where systems and policies can be addressed so that it can be integrated and develop evidence-informed policy interventions. So this is led by CATLAM. And so one of the tools that we have is this policy monitor, where you can search, you can collect, you can analyze different policy tools, policy documents across the world. You can search and you can identify what works and what doesn't work, and what in a particular region has been done to guide other countries within the same context to advance care. And the equivalent of the profile tool at the health systems level, I would say, is the C5 tool, which is this country collaboration for childhood cancer control, that it's set up with 5 modules that was developed starting in 2016 in conjunction with 6 countries working on optimizing and validating. And it's basically trying to address the health systems framework in a way that could provide a guidance for governments as well. And so we'll go very briefly over that, just to show how this worked, working with Ukraine, with Mongolia, with Sri Lanka, over a year process during COVID to try to optimize these modules. And I mentioned that because that led to a very comprehensive analysis of the cancer control systems for children in Ukraine. And so the Ukraine C5 report was shared in a draft form with the stakeholders in Ukraine in December, just right before the war started. So, but that led us to know very well, the stakeholders in Ukraine. We knew the systems. We had been working with the government, with the foundations, with the hospitals, and we had a very good mapping of what happened in Ukraine, the hospitals, the distance from the hospitals to the referral centers. We knew how many patients they were treated in each one. And so this tool basically helped us, together with many other initiatives that we had been doing in Ukraine, to engage with many of those partners as part of our Jude Global Alliance efforts. And so when the war in Ukraine started, we were able to jump in with a team led by Asia to create a solution for them. And so we brought together stakeholders from Ukraine. We brought together stakeholders that we had been working with us in Poland, together with other organizations. And we created the Safer Ukraine system, which was basically an organized evacuation process through Poland that has helped more than 1,000 children in different ways going to a safe place where they could receive treatment. So we organized about 12 convoys. Many of these patients were eventually admitted in Poland, but then about another 630 patients were evacuated to Europe and North America. So the idea was, that partnership, the Jude Global Alliance, the engagement with the stakeholders leads to that natural process of then all working together to create a safer tomorrow for all these children. And so that is, the origin of the Safer Ukraine story. So through here, you have seen how, the SJ Cares framework has grown over the years to create these tools that address different components of this model. And so finally, I want to mention a couple of the slides, what we do in research as well. So the problem as we look globally, we don't have evidence-based practices that contextualize cancer treatment. We lack appropriate structures even to conduct research. We need to define treatment priorities, conduct incremental prospective research, develop new models for research. And so for that, we engage in a thought process that helped us identify what is needed at which time. And so it's not about developing clinical trials. The majority of initiatives that we do are about quality improvement sciences. Then, as we have seen, a significant group of countries then evolve into implementation science approaches and then clinical trials. And so there are many opportunities for each one of those methodologies, from quality improvement, developing, implementation of or assessment of quality improvement methodologies for retinoblastoma, the implementation science, develop an early, a minimal residual disease technology to see if it could be implemented at a national scale in Egypt and showing that that was possible, or a proper clinical trial with a randomized intervention on the dasatinib versus imatinib Philadelphia positive ALL that was done in China because of the larger scale of the collaborative network that we had in China. So there is room for each one of these interventions, and this is how we can develop evidence. And so the Jude Global Alliance plays a role in this global effort to develop evidence, and then we incorporate other areas of research in population sciences, medical anthropology, for example, in epidemiology, as we have seen some of those earlier, or etiological research. So developing evidence at a global level requires this multidisciplinary approach. And for that, we created two big units, the Global Analytics Unit, that is basically our stats unit, led by Mini DeVitas, and the Global Research Support Unit led by Victor Santana that oversees the research operations, all working with different groups within the institution. And with a lot of support that we provide for clinical research to our partners, both in training about clinical research methodology, data abstraction, human subject protection, good clinical practice, clinical research methods, and we have workshops on that, tools, different databases, templates for protocols or for the studies, and then support services, support project management, study design, site coordination, etc., etc. So yes, to start building that capacity so that each region, each country develops evidence on their own with our support and others to generate that better knowledge for the future. So in all these examples that I shared with you, we work with many partners, with SIOP, with IAEA, with IARC, with IHI, with IHME, in many different levels. And you probably can think about, through my talk, about the many areas, the many opportunities to bring partners together and address childhood cancer as part of this global movement that we were addressing. But I realize that we are just running out of time, but I wanted to share with you in maybe 3 minutes. I will try to be quick on that. Where are we going with this? Jude works on 5-year strategic planning cycles. And so One of the goals of the St. Jude strategic plan is, and well, for this time it's a 6-year strategic plan, is to continue to advance and improve cure rates for childhood cancer and catastrophic blood diseases through the St. Jude Global and the Global Alliance that we have been able to set up on the first strategic plan cycle. And so we'll continue to expand the Department of Global Pediatric Medicine and St. Jude Global with the efforts that I shared, but we have put together 4 new initiatives. One, develop regional operational units so that basically are where the problem exists, so decentralize in a sense and be where the problems are. Then expand the infrastructure to run clinical trials around the world, but with clinical trial, I mean clinical research, I should have said, research in general, with all the models that I have shown you. So we develop that capacity at a local level, but also the partners at the global level can be part of our scientific agenda. So there are clinical trials that could be run at a global level, not just at St. Jude or in North America, so that we can share actually what is implementable, what is generalizable, and what is not. But then I will share with you a couple of big ideas that we're trying to explore. One is how to improve diagnostics around the world, and second, how to address the gaps in medications. And so the gaps in medications is something we all know. So even here in the United States, a couple of years ago, there was a shortage of incretin, as you recall. So that made it to the New York Times. A shortage of one drug, incretin. That was not even a shortage, was a threat of a shortage because it was addressed immediately. But that made it to the Forbes magazine, to the New York Times, to the Stat. And so what are we going to do with that? When you see these type of gaps in the United States, you think that around the world, this is catastrophic. This is a tsunami. This is not just a storm. And so a couple of months ago, even the ASH Clinical News, this magazine, had a whole story about the drug shortages in the United States for adults with cancer. And so this is the landscape around the world. So there are children around the world struggling in every country, trying to get these medications. When we have a shortage here, for them, is absence of drugs for months and months. And so global shortages happen every day, every minute. And so just looking at the essential medicines, we're not talking about experimental agents, the essential medicines, there is a mass in this map, and an effort that we did a few years ago. We mapped it and we realized that among 500 providers representing 100 countries, more than 40% of them could not provide consistent access to the full chemotherapy packages. So they had one drug or 2 drugs missing. And so in different efforts that we did in the Philippines or in Asia Pacific, basically we confirmed that was even worse. In some parts of the world, none of the centers actually could get the treatments completed because of shortages. So what are the problems? And I don't think I need to remind anyone. One is availability, the manufacturing. These are essential medicines, off-patent, old drugs that are in the generics market. So this creates a fragmented system for procurement and supply. Often is at the facility level, not at the government level. The forecasting is missing. And then the regulatory systems are quite complex in these cases. So that leads to poor quality of drugs as well, because they are cheap drugs, substandard, falsified products are very common. Governments pay the lowest bid, and so usually it's the lowest quality. And then that creates a unstable market with costs that go all over the place, up and down. And so we know, though, that to take care of children with cancer is not that expensive. I shared with you earlier that the annual cost for cancer treatment about 7 times the GDP per capita, and about 1/3 of those costs are due to direct care. So Nikhil did a very comprehensive forecasting tool to try to understand what are the costs. And so the annual cost of childhood cancer drugs, when we talk only about the essential medicines, which are the ones that you need to cure childhood cancer, is at a global level between 200 and 800 million. For all children in the world, 200 million is nothing, I would say. And half the costs correspond to very high income countries that use, for example, PEG asparaginase that may drive up to 40% of the costs. So for that, together with WHO, we thought, okay, can we come up with a global response to that? And so similar to the Global Fund, create a global platform for access to childhood cancer medicines. that would be based in the World Health Organization Secretariat, working with donors, a procurement agency that would be responsible for purchasing and the entire logistics of distribution, and that would be responsible for the link between the manufacturers and the recipients, then with the steering committee that would oversee that. That's will be part of and technical and community advisory committees. So basically, if you are familiar with the Global Fund, this would be a similar model to the Global Fund. So it's a global platform that would provide access to medications to all the countries. So St. Jude committed $200 million over the next 6 years. We are now in this first phase, the development phase. And so as we start the project, 1 to 2 countries per WHO region. Over the next 6 years will be 12, that then will expand to up to 50, with the idea that by year 2027, up to 50,000 children per year would be able to receive this medication. So in the 5-year cycle, more than 120,000 children would have received cancer medications for free, and this would be good quality medications with no interruptions, because you can do the forecasting, you stabilize the market. So 50,000 children per year by 2027 would be about 1/4 of all children with cancer in the world, about 30% of children with cancer in low and lower middle and middle high countries, and 60% of children in low and lower middle income countries. And then I know that we are running out of time, but I will just say also that the similar gap is in diagnostics. And so we already mentioned that 50% of the children don't even get diagnosed. Through the profile efforts that we did, we realized that in the majority of the countries with limited resources don't have access to the complex methodology for diagnostics. So if here in the US at the NCI or at St. Jude, for a diagnosis of a child with leukemia, we need to go through the clinical, the phenotype, the genetic and molecular to optimize the lineage, the genotype, and the treatment. You can imagine what happens in countries with limited resources. That middle part is completely missing. You need to make a diagnosis, risk assignment, and then treatment when you don't even know what is the diagnostics, and you are just based everything on morphology. So the question is, can we leapfrog? Can we move from morphology to molecular? And that's basically what we're trying to do. So create an opportunity for advancing diagnostics through application of next generation sequencing that, from what we are investigating right now in Intel 16, will be cost effective and could be implemented. And so would perform the genomic sequencing in low middle income countries using a cloud system that provides all the analytics for that are required for the proper algorithm characterization, and with the input lead to a proper diagnostics. And that's basically what we're trying to do. And I will just close here, thinking that the global challenges require, big solutions. And these big solutions need to come by thinking big, but leapfrogging, bringing innovation. And hopefully in the next few years, we can set the tone for improving diagnostics using sequencing, using next generation sequencing, using methylation profiling for solid and brain tumors, using sequencing for leukemias. And with that, I will stop. I know we have reviewed this epidemiological transition, that childhood cancer burden will continue to increase. The advances in the global health agenda have created this unique opportunity to accelerate progress. And we have shown models that we can invest in childhood cancer that is cost effective, that can result in high return of investment. Now it's our challenge to put it all together, to improve access to medications, to improve diagnostics, and put together the packages to develop better future for the children with cancer. And so this is possible. It's just for us now to come together to do it. And with that, I conclude. I'm sorry that I took a few extra minutes. Thank you.
Thank you so much, Carlos. That was a tour de force, as expected. We are really close to the hour. We're going to allow a few minutes more for those who can stay on. Thank you so much. A couple of questions, just looking to see if there's anyone who's raised their hand through the chat. Would be easier than me trying to see if anyone is actually on video. Nina, unless you have someone, I will take the liberty to ask a question first, unless I see any others. Very interesting to consider how you have so many systems, structural things that you're putting into place in a really cohesive and thoughtful manner. is there a way that you could maybe summarize opportunities for those who are a bit older, adults, and also you think of the AYA, individuals with cancer, to help strengthen the health system also to benefit adults with cancer?
Yeah, this is a very good question, Ophira. And you know that we tend to work in compartments and childhood cancer and adult cancers, but I think we need to find this nexus. Some of the tools that we have developed, some of the forecasting that we have developed, or some of the frameworks that we try to develop are applicable to adult cancer. Obviously, there are significant differences in terms of prevention that is not applicable to children. It's much more applicable, much more cost effective for adults. That probably should be the priority. But in terms of integrating this into the health systems, creating this engagement with governments and with multi-stakeholders, and then creating these tools, bringing the methodology, improvement, implementation, science into the equation, I think it's something that can be applicable to AYAs and adults.
That's great. And I don't see anyone else having questions at this time, possibly because we went a bit longer, but it's great that you'll have an opportunity to speak also with trainees, et cetera, after this session. And for those of you who aren't aware, we are going to have a capacity to post the recording on our website. We guess we really should probably wrap up. I'm just going to say thank you again so much. Oh, I just see one more question. Does the Alliance work with Global Hope, Hematology, Oncology, Pediatric Excellence? Carlos,
Yes.
Just a quick answer, please. Thank you.
Yes. We have many areas of collaboration as well. And yes, we have some communication with Global Hope as well in Africa. Yeah.
Wonderful. Thanks so much. This unfortunately does conclude our session today. Very special thank you to Dr. Rodriguez-Galindo and to all of you for joining us right until the end. Our next session will be Thursday, June 9th with Dr. Susan Horton of the University of Waterloo, Canada, and Dr. Shaheen Sayed of Aga Khan University, who will present Transforming Global Access to Cancer Diagnostics, report of the Lancet Commission on Diagnostics. Once again, please visit our website, cancer.gov/global health, for additional information and all the past recorded sessions. Thanks again, everyone. Bye-bye.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.